So, how to take it? This is UK, but it applies everywhere. I think generally speaking, most jurisdictions, but not all, of course not in Canada and other US states where it's totally legal anyway, I can't recommend it. I can't prescribe to smoke it. The reason for that is probably because the burn temperature is high when you smoke, and then you get the tars and the carcinogens produced. There's actually very little evidence, in fact some evidence opposite, that smoking a joint does not cause lung cancer. There's some studies that say it does. I think the majority of the opinion is that it doesn't. That's true? Oh good. This table's very good, this table. They're going to get the prize. They've applauded, no one else has yet, so we need to spread this table around the rest of the place. And it's very significant individual variation smoking, so it depends on how much, how your duration of depth and puff and breath hold. So it's not as easy, medically speaking, to control anyway. So I sort of see the point of not smoking, particularly because it's vaping. That picture's totally irrelevant. I just like the picture. It's nothing to do with anything really, it just says you can't smoke it. So you can vape. And the advantage of vape actually most of the prescription in the UK, from our vast experience of 22, is actually for vaping for pain. And the advantage of vaping for pain is that there's a fast onset of action. So for breakthrough pain, particularly sudden pain, you can get a relatively immediate effect within minutes, usually. It lasts, of course, a short length of time, which is good in some ways and bad in others. You might want a background effect, but you might want a more acute immediate effect that lasts only a short duration of time, so it lasts just 2 to 3 hours, and it's quite good. Better bioavailability is quite good. I'll come to that summary slide in a moment. So vaping is probably therefore better anyway than smoking, and of course the vape temperature is less, so you don't get the burn off of the toxic components so much because it's a lower temperature. So there's vape types is convection, which they heat up the air which passes through the flower, or conduction, which actually heats the flower directly. I don't think that's a very personal preference. Some prefer one, some prefer the other. I don't think it hugely matters whether you use a convection vape or a conduction vape. People have a huge amount of argument and discussion online, which is probably irrelevant. The temperatures, and you've got to know this, I suppose. If you're going to prescribe a flower for vaping, you need to know, and a lot of people you're prescribing for won't know what on earth to do with it. They get a bag of flour. What the hell do I do with this? First thing to do is to buy a vape machine. Those with different temperature settings are the best, because depending on what temperature you set, you get different effects, because the different terpenes or the different cannabinoids come off at different temperatures. Then say if you go at 200, 210, so it gets rather subtle. And many of the modern vaping machines, you can set it at 200, so it's not difficult to do. You put your flower in, you set it at 200, and you vape it. So the lighter terpenes come off first, then you can read it for yourself, so you get different effects at different temperatures. There's a point at the bottom there. Don't use street cannabis for vaping. A lot of people do, but because some of them is high in ammonia, and you don't want to inhale that too much. I don't know if that's a relevant point particularly, but we're only talking about medical cannabis here anyway. Or a lot of people just need it as a pen, and you take it out and you smoke it, just like the e-cigarettes, exactly the same as the e-cigarettes around at the moment. And some of those are very good and very controllable. Some of them they don't look labeling you these days. They're looking very quite smart machines. And some like this one, for example, you can set the temperature. So there's a whole industry around different vape machines that I don't claim huge expertise at, but I think it's worth just getting one or two that you are, as physicians and prescribing, are familiar with, perhaps one for the pocket and one for the desktop, and offering some training on that. Most clinics actually use a nurse or an expert to go through the vaping process for half an hour with someone who don't know, and it doesn't have to be medical at all. There's plenty of recreational users who can teach people that very perfectly well. But it's probably worth doing that rather than waste in medical terms 30 minutes extra on the patient to teach them about vaping. This is the original vapor. No, it's not even a vape. I just like the picture again. I don't know what he's doing with that, but it looks impressive. Okay, so you can vape it. You can spray it, and the only spray I'm aware of at the moment is Sativex, which is a 50-50 THC CBD, and it gives a metered dose. It's actually quite good to give a metered dose. I think and I saw one 2 weeks ago in a CBD Expo in London, where they're getting easy metered doses like for asthma medication, which I think is probably very good. Just a couple you probably haven't available here yet. Take 2 sprays 3 times a day, whatever it is. It's a metered dose. It makes a lot of sense. So that we'll get much more refinement in the coming year or so about all this machinery that goes with it, if you like. At the moment, it's a little bit hit and miss. You can put it in edible. We can prescribe edibles in the UK. I don't think anyone has yet prescribed an edible, but obviously you can prescribe an oil, and you can put the oil into, you can make food out of the oil, of course. The advantage of edibles as a prescription entity is a slower onset of action, which may be useful for some, half an hour to 2 hours roughly. It lasts longer, obviously, 6 hours-ish, sometimes a bit longer, sometimes a bit less, depends on the person. There's not so good bioavailability because it's subject to first-pass metabolism. Although interestingly, the first-pass metabolite is 11-hydroxy-THC. Someone tell me that's right. Thank you. And that is 5 or 6 times more potent than THC. So there's less bioavailability because a lot of it's wasted in first-pass metabolism, but the metabolite you get is more potent. So actually the bioavailability is not too bad from edibles for that reason. So you can do it in all sorts of food. There's a problem with this, KitKat. There's an example of it. There's a lot of criticism at the moment in Canada and some in the United States that this makes it very accessible by accident to children, for example, who see a KitKat and take it, and actually it's not a KitKat. If KitKats are familiar in New Zealand, I guess, yeah. And there are difficulties with making it too attractive for children. I understand that criticism. But you can, I don't think we're yet at GPs prescribing mixed greens with marijuana vinaigrette 3 times a day or something, but, it's there. And this is slightly sensible in that if the more palatable you make it, the more people are going to, the more compliance you're probably going to get. And it's a perfectly good way of taking it. And you can take it, again, there's a criticism over using it as chocolate, for example. So, dissolving, it's not water soluble. It's very lipophilic. There are technologies that you can make it effectively water soluble, for nanotechnology, very, very small particles, so you can effectively make it water soluble, though it's not, strictly speaking, it isn't. But nevertheless, you can get it into drinks that way. So people are beginning to do that, and again, more choice will emerge in the coming months, probably. You can use it as a cream, quite useful for localized joint pain, for example. My 94-year-old mother uses a CBD cream now. She tells everyone her son prescribes it with cannabis. She's very popular in the nursing home. Everyone trying to use the THC cream. It's just a CBD cream, but nevertheless, she's very popular. I think I have to buy it for her, and she must be giving it to most of the nursing home because the amount of stuff I'm buying for her is ridiculous. I think she's probably selling it and making a profit or something. But that's quite useful. There's very little systemic absorption. There is some, as with any cream, but it's only for localized use or for skin conditions. We heard about acne earlier. It can be useful for eczema and things like that. Basically for medicine, we're tending now to prescribe predominantly oil. Oil, of course, that oil can be encapsulated in a soft gel capsule, which makes it a bit easier to prescribe. Standard 1 capsule 3 times a day or whatever it is, or 3 drops of oil 3 times a day. So most prescriptions now, or in fact all prescriptions in the UK are either for oil or for vaping. And we haven't got the other methods as yet. So we're looking at oil droppers. It can, of course, be used in other formats, such as rectally, which is quite useful for those who have difficulty swallowing, for example, vaginally as well, and topical patches, also potentially useful as a way of absorption as well, or little tiny strips they're doing these days in the States and Canada with a metered dose. You just slip it under the tongue and it dissolves quite easily. So there's a lot of ways of giving it, but I think for all practical purposes in the early year or so of general prescribing, I think most people are going to use oils or vape, or dried flower for vape. Just the bioavailability, smoking is hugely variable. As I said, vaping is about 40% bioavailability, so obviously if you prescribe a milligram, you're getting 0.4 of a milligram very, very crudely. Edible is hugely related to 6 to 20%, but variable, much less, but it does convert, as I said, to 11-hydroxy, which is 4 to 5 times more psychoactive. So it sort of compensates for the low bioavailability. Sublingual about 20, rectal with no first-pass metabolism, a little bit higher, up to 40%, and topical is virtually nothing. Interestingly, CBD is much more potent topically than THC. Right, let's move on to the clinical evidence. This could take forever, so I'm going to just summarize it at a sort of top level. And I'm going to use my report first of all, and before you say, well, that's biased and you should use others, I am going to compare what I said to the American Academies, Science, Engineering and Medicine, which is probably the definitive report these days, 2017. There are other reports around. There was one for the Irish government, there's one for the Australian government, and there's general papers in the literature, Whiting et al. And one, there's 2 or 3 good summary reports. Broadly speaking, they all come to the same conclusion, broadly speaking, with some bit of tweaks here and there. But I'll say what we did, we being me and my daughter, if you remember, I think I said that earlier. We reviewed all the literature on medical cannabis. There's about 20,000 references, which the government in typical fashion asked us to do in 1 month, which we managed, actually, 5 weeks. We ranked them according to the American Academy of Neurology criteria, which basically is this. I'll let you read it. It's a Class 1 study, is a proper randomized controlled clinical trial with objective outcome assessment, blind allocation to groups. Class 2, Class 3, Class 4, less robust, if you like. But I do want to emphasize again that cannabis does not lend itself to the standard pharmaceutical models of trials. I did this probably even 2 or 3 years ago. I was relatively ignorant, but nevertheless, I thought we ought to go along the standard route that people understood at the time, because it was highly political, this thing, and I didn't want to get too controversial. Maybe I should have done, but I didn't. So this is what we rank those studies into Class 1 to Class 2, 3, and arbitrarily I called good evidence at least 2 Class 1 studies, positive of course, with a theoretical basis and other evidence to back it up. Moderate was 1 Class 1 study, some was no Class 1 studies, but some other Class 2, Class 3 evidence, and no recommendation for the rest. Doesn't mean it didn't work for the no recommendations, it means that the studies weren't there. So this was arbitrary, but at least it was something that we could say, and the politicians wanted to know what's good evidence and what's not good evidence. So that's what we did. And it was quite a high barrier, really. I was like, what we didn't want politically was this to be criticized and say, well, he's just in it for the money or whatever. He's just promoting it because he's an activist and whatever. So we wanted to make this pretty unarguable. And surprisingly, not many people argued about it, I have to say. Perhaps a few people read it, but no one much argued about it. So what would you find good evidence for? Number 1, above everything else, is chronic pain. I don't think there's any doubt about that. The Royal College of Physicians of the UK determined when they set their guidance out, there's not enough evidence of prescription in pain, so it shouldn't be used. I think that's probably the worst report and guideline from an august body I've ever seen. It flies in the face of all evidence and is largely responsible for the lack of prescription in the UK. So I think, I'm a member of the Royal College of Physicians. I think if I criticise them much more, I won't be for much longer a medical member of the Royal College of Physicians, but I think that's an appalling report. There is 11% of the population have chronic pain. There's good evidence for a whole variety of nabiximols is Sativex, I'm sure you know. There's studies also on the synthetics and studies on smoked. There's surprisingly little therefore on oil and the other forms I mentioned earlier. There's 8 Class 1 studies positive, so that's pretty, it's okay. Of course we need more evidence. We need much more evidence about what format to give it in, what dose is good, what variety THC versus CBD is better for pain, a lot more. It's endless. We're learning about it, in decades' time. But I think 8 Class 1 studies, plus what they now call nicely the real-world experience, of Canada and the States and emerging in Australia and here and elsewhere is no doubt whatsoever that it's useful for chronic pain. All pain, neuropathic particularly, but also post-surgical cancer, arthritic, etc., etc. It doesn't seem to matter what pain. And just that one study at the bottom, I tried to get the reference, I couldn't find it again when I was looking last week, but there was a study, forgive me for not remembering where it came from, 1,200 patients, over 50% rated their pain as 8 to 10 out of 10, bad, but only 4.6 rated it that after cannabis. 91% improved nausea, 87% better sleep, 84% improved anxiety. So that's the sort of number 2 for good evidence is spasticity. Not surprisingly, the work's been done on Sativex. And Sativex, it is in the UK, I don't know it here, it's licensed for drug-resistant spasticity in the context of multiple sclerosis. Okay, the studies were done in MS, but spasticity is spasticity is spasticity, and there's no reason why it shouldn't work in motor neuron disease or stroke or brain injury, spinal injury or whatever, and indeed it does. And the evidence is basically on Sativex, but of course it doesn't mean that the other forms of cannabis don't work, and whether you need a 50-50 ratio is not really known. That's number 2, spasticity. Number 3 is anxiety. CBD effect, just CBD. I think there were 2 class 1 studies on anxiety. That should be predominantly CBD and not THC, because THC is anxiogenic, as we said earlier. So that's a third thing, anxiety. 4th was nausea, and even the Royal College of Physicians said there was enough evidence for this, so there must be. There's 23 controlled trials and a Cochrane review of this, and I think there's absolutely good evidence for several different formulations, and there's no doubt that THC and CBD, and again, we don't know the detail of what proportion works for nausea and sickness. And I think it should work in hyperemesis gravidarum as well. It's an unusual thing to say, but people get very ill in hyperemesis of pregnancy, if they're not, and they use very potent drugs. And the last one is, come here, epilepsy. We didn't actually say epilepsy because even 3 years ago, the evidence for epilepsy was still a bit minimal. It isn't now, and I have no doubt, there is no doubt now, that particularly CBD is helpful, particularly for childhood drug-resistant epilepsy, but as epilepsy is epilepsy is epilepsy, and I don't see why it shouldn't work, and does indeed work for adult epilepsy as well. But the studies have been done. A lot of the studies on Epidiolex for Dravet and Lennox-Gastaut, and broadly speaking, as it says there, 43% of children improve at least 50% in seizure frequency. For full extract, you need a lower dose, and roughly the dose used in this study, for example, was about 13 milligrams per kilogram of CBD combined with 2.7 milligrams per kilogram of THC. That's quite high. But the seizure frequency was 70%. 63% of children got at least 50% reduction, which compared to 43% in Epidiolex studies. And that's generally, if I can generalize, there's now 3 studies of this type, not brilliant quality, but nevertheless it seems likely that the full extract cannabis works for more people with less side effects, because you have to use a lower dose. And it's important to remember, I think it's key to remember, that the isolates need higher doses. The dose of Epidiolex was in those studies roughly 1,000 to 2,000 milligrams, whereas the dose in full extract CBD averages about 300. So it's between 3 and 4 times more for isolates. So isolates need higher dose. And it's important to remember that. There's several doctors in the UK who've suggested full extract should be at the same dose as Epidiolex. It shouldn't be. It's much less. And also there's improved quality of life measures. There was some evidence of liver enzyme increase, but only on those who are also on concomitant sodium valproate. So it's early days, but most of the children, if not, in fact, all of the children in the UK currently on medication are on full extract products and not Epidiolex. Although Epidiolex is available in the UK on a compassionate use basis. I'll pass over that because that says the same thing. CBD-RICH extract versus pure CBD. Again, showed what I've just said. The dose at the bottom, 6 milligrams per kilogram versus 27 milligrams per kilogram was the improvement rate. Okay, they're the 5 I thought was good evidence. I'll compare this to the Americans in a bit. So that was pain, it was anxiety, it was spasticity, it was nausea and vomiting, the context of chemotherapy, and it was epilepsy. Moderate evidence, if you remember how we defined that before, was at least one class 1 study, without going through too much of the detail. Appetite stimulation, particularly in the context of HIV. Fibromyalgia, they could argue whether that's the pain and the anxiety or both or whatever, but just for fibromyalgia as a diagnostic label, there was moderate evidence. Sleep disorders, not surprisingly, and also for PTSD. You can argue that's the anxiety effect as well, but for PTSD, that's quite widely used, particularly in the States and Canada, as a treatment for PTSD. So they were the 4 things we labeled as moderate evidence. I think enough to prescribe for those things, particularly as some of those are very difficult to treat otherwise, or you have to use quite potent other things, other pharmaceuticals. So I think it's worth seriously considering this. Some evidence, interestingly, agitation in dementia, interestingly, glaucoma, which was, if you remember from the first slide, I think, that was the first description of its use. Bladder dysfunction in the context of MS, they worked those studies. Motor symptoms of Parkinson's disease. If you look on the internet, actually, it gets a bit anecdotal, but there's some remarkable films of people with Parkinsonian tremor that stops instantly. They take a puff. I mean, it really is quite extraordinary, some of those things. Okay, we have to dismiss. We're taught to dismiss anecdotal evidence. I'd like to, how many anecdotes make evidence? I mean, 1 anecdote isn't evidence. 10 anecdotes saying the same thing, we have to take, okay, take that a little bit seriously. 100 anecdotes, well, pushing it now. 1,000 anecdotes, how many anecdotes make evidence?
It all starts with anecdotes.
Exactly.
Right.
Exactly. There's a company in Canada that has 10 million data points on their patients. Wow. All anecdotes, so it's rubbish. You know, can't take any notice of that. 10 million data points doesn't mean a thing, because they haven't done a randomized controlled trial. You can tell I have a bit of a hobby horse about randomized controlled trials, can't you? Some evidence for that. And no recommendation, if some of these are interesting. This is, again, I don't want to emphasize this doesn't work. It meant we couldn't find any, if you like, standard pharmaceutical type evidence for these things, for dystonia, for Huntington's, for headache, interestingly. Depression, that's surprising, because that's, as I said earlier, that's the second commonest use of medical cannabis in the UK, is for depression, but there's no studies. And another interesting one is I'm told recently in Canada, 50% of people with Crohn's disease, use a bit of one of these, 50% of Crohn's disease people use cannabis. I found that extraordinary. I presume it's true. But that's another interesting, there's another room for a lot more studies on that. There's a very recent study on the antipsychotic effect of CBD, so it might be worth revisiting this. And the other one is cancer. There's a recent debate in the European Parliament on the use of cancer. The actual anti-cancer effect is very clear in animal studies, less clear in humans. But there are, again, a lot of anecdotal reports of cancers melting away and such like. But I just simply say that. There aren't studies. It seems that some cancers are much more susceptible to cannabis than others. But we shouldn't forget, as I said before, even if you don't believe the anti-cancer effect, cancer is very useful for treating the anxiety associated with cancer, pain associated with cancer, if necessary, muscle spasticity associated with cancer, sleep and appetite improvement. So we shouldn't forget that it's a very useful symptom treatment, whatever you've got. So I think its role in cancer is a bit misunderstood sometimes. But they're the things we found, and let's have a quick compare to what it's a book, if you've seen it, it's a very, very thorough resume of 2017, and they said there was conclusive or substantial evidence for chronic pain, antiemetics, and MS symptom spasticity. I totally agree with those 3, conclusive or substantive evidence. And those 3 are pretty certain in the literature. They said there was moderate evidence, and I won't bore you with how they defined it, but broadly similar way, for proving short-term sleep outcomes in some conditions. And there was limited evidence for increasing appetite, Tourette's, anxiety, and PTSD. The only thing I differed with was anxiety. I've moved it to a bit of a higher evidence-based category than they did. But otherwise, these things are broadly similar. Interesting, they looked at what it was ineffective. You've got a sort of a double negative in here. Limited evidence that it's ineffective, if you can work that out. Limited evidence is ineffective in dementia, improving intraocular pressure in glaucoma, interestingly. So they thought overall it was ineffective in glaucoma, which is its oldest use, which I find odd, and depression. I don't agree with that last one. I think there's no evidence for depression, not evidence that it's ineffective, but no evidence that it's either. Although a lot of people using it must mean something. So that's what they found. So I just report it in fairness. They found insufficient, again, doesn't mean it didn't work, but they found insufficient evidence for use in those things there, similar to that which I found as well. And at the time of writing, they found insufficient evidence for epilepsy. But again, 2017, even over 2 years, that's now out of date. I think they would move it up to conclusive evidence for some epilepsies. Okay, very quickly, that's evidence. I'm sorry, that could have taken an hour or more in its own right, going through all those studies, but I recommend, perhaps, I can't recommend myself, but yeah, why not? And the National Academies is worth looking at. That's a very thorough paper. Yes, sir. Shout it. Where's the thing gone? Here it is.
Just a really simple question.
Yeah.
Why do you have a problem with randomized controlled trials? Can you explain why?
Yes.
Why do you have a problem with randomized controlled trials?
Yeah, because cannabis is a very personalized medicine. If we take pain, you start with a CBD product, right? Very crudely, around 20-25% of people with pain will improve with however you define improve. Let's say they improve with a CBD product. That's broadly the same as placebo effect. So the study, a standard pharmaceutical study, CBD product versus placebo will be negative, almost certainly, as the side effect studies were. So what you do clinically is if that doesn't work, you move up to a more balanced THC CBD product. And again, you're going to get around 25% of people responding to that. So take that product in isolation is negative against placebo. If it doesn't work, you move up to a higher THC product. You take that in isolation, it'll be negative against placebo, because all of them help about 25% of people. If you take the totality of all three of those together, if you take that as one treatment entity, if you like, moving up the ranks of the products from CBD, balanced, high THC, then about 75% will improve, 75-80% of people will improve, which is much significant against placebo. Now, it's not beyond the wit of man to design a proper randomized study that takes the totality of the treatment of all 3 or 4 or 5 products, but the standard pharmaceutical study of one product versus one placebo will not work. And there will always be, virtually always be, negative against placebo. That's why.
But why not just do a trial of the whole class?
Well, exactly. You can do that, but most sort of pharmaceutical minds said that's not right. But I quite agree, that's easy to do that. Let's take a randomized control study against placebo using this sequential increase against the whole plant. 2 or 3 strains, 3 or 4 strains, then it will be positive. So I'm only complaining about the single product randomized trial with one product, one placebo. It's easy to design it. It's just people need a bit of lateral thinking, I think. Where's my thing gone? I've lost my twiddly thing now. Here it is. Let's have a look at the long-term effects. How are we doing? We're all right. I think I missed some, dear. Yes, I did. I missed the whole of short-term side effects. Generally speaking, CBD is remarkably safe. I can't say it has no side effects, but it has very, very few. Very few. The more THC you have in the product, the more side effects you get in the short term, and the long term for that matter, but short term at the moment. The main short-term problems, which are dose-related to THC, are 4 Ds, disorientation, dry mouth, dizziness, and drowsiness, and others, but it's nice to have 4 Ds together. So let's look at, this was a nice paper, which was reviewed 62 studies, Whiting and al., 2015. I think it was one of the neurology journals, I think. Forgive me if it's not, you can easily look it up. 62 studies, so it means something. There's a lot of people here. And they did the odds ratios, I'm sure familiar to the audience, and the odds ratios, and this, again, it was THC related largely. So the top was disorientation, as you'd expect with a psychoactive thing. You get the dizziness, euphoria, the high, if you like, confusion related to that, and then drowsiness, dry mouth, you can read it yourself, going down and right down to the bottom odds ratio of psychosis, which I'll come to in a moment. So they're the short-term immediate effects, and of course, how long they last depends on how long you've taken it. It could last a couple of hours for vaping, it could last 6 or 8 hours for edibles, but usually then milder, because the total dose is somewhat less, spread over a longer period of time. None of those are unexpected, but you need to warn the patients if they haven't used it before. But there again, you wouldn't usually start with a high THC product, so you wouldn't normally get those effects if you start as standard with a really high CBD product. But that's the sort of short-term effects you get. The media and others are quite rightly worried about longer-term effects, and that's the one you hear about all the time is schizophrenia and psychosis. And I think this was, we looked at this very carefully. There's a lot of literature on it. There's a lot of confliction. It's not clear-cut. It's not clear-cut. There's a recent paper in the Journal of the Medical Association that refuted the association altogether, if you saw that. It was, if you like, it was those with schizophrenia or psychotic illness, the psychiatrists among you, forgive me for the moment, were more likely to smoke cannabis than the other way around, if you see what I mean. So it was almost a personality type were more likely to smoke cannabis, but those who were more likely to get schizophrenia. So it was cause and effect. But anyway, I think probably the evidence is that taking high THC, remember, not CBD, that's antipsychotic, high THC can probably exacerbate symptoms in people already suffering from psychosis or with a family history of psychosis. Another recent study, I should have put the reference, sorry, it's very recent. Heavy cannabis use in schizophrenia was 2,800 numbers to prevent. So you've got, again, that was less, 4,000 in the young people, and more, 4,700 numbers to prevent in 35 to 39-year-olds. So, yeah, that's serious, but we've got to put it into the overall context. So I don't want to play it down, and I wouldn't prescribe for schizophrenia or for a problem in the person who has schizophrenia, personally. Dependency, cannabis dependency syndrome, again, we're talking about high THC street cannabis is about 9%. Roughly, that's the standard accepted figure. Cannabis dependency syndrome compares to about 15% to alcohol and 32% for tobacco. Again, if someone's got cannabis dependency already from street cannabis, I probably wouldn't prescribe for them or under very controlled, very carefully monitored circumstances. Driving, again, THC, you shouldn't drive when you're under the influence, like alcohol, to state the obvious. Lung cancer, I think that evidence is very thin for lung cancer, but in any case, that's smoking and not vaping. Cognition, again, there's some short-term effects, clearly, and there's a few papers that have shown a long-term effect on cognitive in the more vulnerable, inverted commas, adolescent brain. And I think I'd be cautious about prescribing a high THC product for an adolescent. But there's no firm argument against that, and there's some papers recently that have refuted any long-term cognitive damage. So it's controversial. I think we have to accept that there's limited evidence for any short-term or long-term cognitive damage. And as you've just said, some studies have shown there isn't any. There's some studies that show reduced brain volume. I don't know what that means, and no one's shown it's correlated with any damage. I don't know what it means. Okay, so what? The so what's missing from those studies. What else can you get? Very small kind of cannabis hyperemesis syndrome. Again, high THC street cannabis. You get profound hyperemesis. I've never seen it. Well, but if anyone has, that's the thing. It's said you can help that by taking a cold shower. Increased pulse rate. I'll come to contraindications in a moment. Tachycardia is an issue with THC. It doesn't matter to most people, but if you're cardiovascularly vulnerable, it might. You can get the whitey, as they call it, with alcohol. If you shouldn't, you can. I don't know. Who cares? You perhaps best not to drink a lot when you're taking cannabis, because you can feel awful and drained and sick and vomiting and diarrhea and such like. It's not a pleasant experience. So allegedly. An overdosage, the thing that everyone says, because it's true, is that you don't die of a cannabis overdosage. I think that's quite okay if you get psychotic and run under a bus, but actually primarily from the cannabis, you don't die of a cannabis overdosage. You die of opioid overdosages. Many thousands of people do every year. I think that's worth bearing in mind. For those who are a bit worried about prescribing, they haven't done it before, I said this to an audience of lay people, they were shocked and horrified at me, but you can't kill anyone. If you make a dreadful error with cannabis dosing, you don't kill them. They may feel awful for a few days, but you don't kill them off, and that is very useful. Is this being filmed? It is. Where's the cameraman gone? Here he is. Cut that bit out. But it's seriously, you get ill, you get increased pulse, extreme anxiety, paranoia, psychosis, if a serious overdosage of street cannabis largely, but you don't die of it. Okay. Whoa, I have 10 minutes. We do a bit of this afternoon as well. Contraindications. Well, I've sort of covered that, but let's have a look at it. I wouldn't prescribe with psychosis or schizophrenia in a first degree relative, in a family history. We've said that. Mania. These were, I'm going to blame my colleague here. These were slides from my colleague, Dr. Danny Gordon, who's come from Canada, has a very large prescribing experience. She doesn't prescribe for those with mania. Would I or not? I don't know. I wouldn't prescribe a high THC product, probably. She doesn't prescribe if you've already got a cannabis dependency, a cannabis use disorder. Fair point. I think I probably would, if necessary, if there wasn't an alternative. But with caution and with a lot of follow-up and oversight. Pregnancy, like anything, I have said before, for hyperemesis, if people who have a serious hyperemesis in pregnancy and use very powerful antiemetic agents for cancer-type antiemetic agents, personally I would use cannabis instead. There's no serious evidence of a cannabis fetal type syndrome. It's not ideal, but if necessary in that particular circumstance, I think it's probably reasonable. But generally speaking, like any drug, you wouldn't recommend using it in pregnancy or breastfeeding. What's the other one? History of suicide or suicide? I put a question mark there. Danny didn't. I don't think there's any evidence of increased risk of suicide, but I put it there for debate, really. For those who prescribe, would you use it in someone who had a history of suicide? Not a history of suicide, attempted suicide. You would? Yeah.
To reduce anxiety.
To reduce anxiety, yeah. So I put that's my question mark, and I think I don't agree with that. I think she's too cautious. What are the relative contraindications? And again, I think she's too cautious. But she doesn't prescribe immediately, and I don't know how she defines immediately after myocardial infarction or stroke or cardiac arrhythmia, and I think that's primarily because of the tachycardia and increased heart work, to put it like that. She doesn't prescribe in cirrhosis because of I think THC progressing fibrosis. That evidence is pretty thin. If you look at the cardiovascular risk, coronary arteriocerebrovascular disease, heart failure, any arrhythmia, and I can see that point. If you've got an arrhythmia that may be worsened by a tachycardia, then maybe that will be unwise to prescribe. I can see that. Do cardiologists want to disagree with that? Are they in the audience?
Surely just a high THC.
Yeah, I think we're talking about high THC. I don't think any of this really applies to CBD.
Thank you.
And I have to make that clear. Sorry, I should make that clear. We're talking about high THC. And as I said already, not many medical patients need high THC. So these are relatively small print stuff. I would go personally, I think a balanced THC CBD product is perfectly okay for most of these things. You don't tend to get the tachycardia with that. It's high THC. I think we sort of covered this dose-dependent tachycardia, increased myocardial contractility was the reason why you want to be cautious immediately after heart attack or existing cardiac difficulties. I think that's all the point is trying to make there. High THC, cardiac problem, be cautious. I don't think there are any significant drug interactions for which you wouldn't prescribe cannabis, with two exceptions which I'll come to. There are theoretical problems which are on these slides. I'm sorry there's so many words on this slide. Let me look at it. Interactions, the effect on THC, okay? THC is metabolized by cytochrome T2C9 and 3A4. There are people who are poor metabolizers of 2C9, and they therefore would have higher concentrations of THC. Yep. For example, threefold, about 10% of the population are poor metabolizers, so that's why we start with a lower dose in case they are, and effectively are then getting higher THC concentrations. But there are no studies examining the effect of 2C9 inhibitors on elimination of THC. But inhibitors of 2C9, bear with me, keep focusing, lunch soon. Inhibitors of 2C9 will be expected to increase the plasma concentration of THC. 2C9 inhibitors include that lot. So if you're on that lot, you might be expected to have a higher amount of THC circulating. It doesn't, in practical terms, doesn't seem to make any effect. It's the theoretical problem. 3A4, similar list of drugs there, third line up, clarithromycin, erythromycin, etc., verapamil. They expect you similar increases in THC. A 3A4 inducer should have lower levels, and probably the one that's been looked at, rifampicin, is about 20 to 40% lower THC. CBD is also 3A4 and 2C19, so the same things apply. If you've got drugs that inhibit 2C19 or stimulate 2C19, you may have an effect of the plasma concentration of CBD. Rifampicin, for example, will reduce CBD by 50 to 60%. But again, in practical terms, it doesn't make much difference to the CBD or THC levels or what you're on. So I don't think that needs to be borne in mind particularly importantly. Maybe more important is the other way around. What effect does THC, CBD have on drugs that are already taking for other reasons? So THC and CBD have a limited ability to inhibit the activity of the various cytochrome 450 enzymes. There's one case report that shows that warfarin, I think you need caution in warfarin, you just need to take the INR more frequently, probably. And this was a very limited, this very, very limited data. This was a patient taking 4 to 5 joints a week, which isn't much at all. So that needs to be borne in mind, had an increased level of warfarin. Theophylline, chlorpromazine, about 50% reduction in the plasma concentration of theophylline and chlorpromazine. Probably no induction of the 1A2. The one that I think is more important is, where is it, clobazam. Is it on there? Can you see clobazam there? Not clonazepam, clobazam. It's meant to be there somewhere, perhaps on the next slide. Anyway, clobazam is, there's a study recently that purported to say that the anticonvulsant effect of CBD was all due to the fact that it increased clobazam levels by methylclobazam. Desmethylclobazam is the metabolite, which is increased in CBD. And therefore the improvement in epilepsy is simply due to the increase of clobazam. And if you're on clobazam concomitantly, you do need to monitor clobazam levels. But that paper failed to notice that there's an improvement on those who are not on clobazam. Mine had difficulty with that argument. And also, of course, not all children who are on clobazam have changes in their levels. Alfie, for example, is on clobazam, and that's made no difference to his levels of clobazam being a high doses of CBD. But nevertheless, I think warfarin and clobazam need monitoring if you're on those concomitantly. The other ones to think about, the pharmacodynamic interactions, like, I shouldn't put marijuana, it's not a good thing to use. So if you're on central nervous system depressions, like alcohol, you shouldn't mix the two. Other things that cause tachycardia, you shouldn't perhaps mix the two. It's obvious stuff. But in terms of, I've got a lot of questions say, I'm on this, can I take CBD or can I take THC? And I think that basically the answer is yes. It's very safe to interact. I've nearly finished. What have we got here? I've forgotten. So this is a mystery to me. It's a bit of a pre-lunch mysteries tour for, I think, 4 slides. Other points. Hemp we've mentioned about CBD. CBD is legal in the UK. People do get hemp, and hemp does not contain as many of the cannabinoids. It's been bred for different purposes. But people do use it in the UK. It may not apply here, but you can't say it's a medicine. So you buy it over the counter at health food shops, and then people write and say, what do I do with it now? How much do I take? And the people selling it can't tell you because they're not allowed to tell you. So it's a very unsatisfactory situation, and I can't prescribe a CBD hemp because I can only prescribe a product that is designed, is manufactured as a medicine, and by definition, hemp-based CBD is not manufactured as a medicine, so I can't prescribe it. So ironically, you can buy it on the shop down the road, but I can't tell you anything about it, which is a ridiculous situation. And I think you should do all you can to avoid that in New Zealand if that's a possibility. You know, it's much safer than THC, much safer, but we can't say anything about it. It's ridiculous. A couple of quick, almost political points. Does medical approval lead to increase in recreational use? The answer is from the American states where we've got nice comparative studies in the states. Of course, one state, yes, legal, and one state not legal. And the answer is no, it doesn't. There's bound to be some leakage. Of course there is. Somebody's going to nick Granny's cannabis and try it. But generally speaking, once they've tried it, they're disappointed because it's got mainly CBD in it and doesn't get you high, and it's far better effect on the streets. After nicking Granny's cannabis once, they don't do it twice. But there's no evidence of increased recreational use if you make it medically available. And some people have said that. I put that as a political point. There are some anti-cannabis campaigners who say that it will increase recreational use. It doesn't. I think it's important to make the point about opioid overdosage. That's a real issue in the States, as you know. In the US, 64,000 people, that's a massive number, died of opioid overdose in the States in 2016. If you go onto the pain specialist, better than I do, you substitute, or you go onto cannabis, you can reduce opioids overall by about 25%. Some will stop altogether. It's all 25% less deaths, 25% less prescriptions, and 25% on average less dosage of opioids. And no recorded overdose deaths from marijuana. So on no other political grounds at all, if you want to say how that would translate into New Zealand, I would give a wild guess 1,000 opioid deaths a year. I mean, of that ballpark figure, I don't know, something like that, roughly. So you'd save 1,000 deaths a year by introducing cannabis, what more for pain, substitute for pain. I think it's worth doing on those grounds, personally, but it's a point worth making. You can reduce opioids and all the effects of opioids. Well, I think I've just said all that. Money. Yeah, people say, just a totally political point just before lunch, really. Cannabis costs money. It's actually quite cheap. And the moment in the UK, it's ridiculously expensive because it has to be imported patient by patient with all those costs. The average cost per patient is about £800. That's about between 1,500 and 2,000 New Zealand dollars per month for a prescription, because it's imported specially for that one person from Holland or from Canada or Australia. But what people forget, I think, when they're looking at that cost is actually what you save on reduced analgesics, opioids particularly, anti-anxiety drugs and anticonvulsant drugs and hospital admissions. And we did a quick back-of-the-envelope thing. I shouldn't be too anecdotal, should I? But for Alfie, what I keep mentioning, and we reckoned that Alfie with 48 hospital admissions in 1 year, we saved about £100,000 by prescribing cannabis for Alfie, even though it costs basically £4,000 a month at the moment to get it for him, because it's expensive, because it's imported specially. But that's compensated by the loss of hospital admissions and less other anticonvulsant drugs. So if you're looking at cannabis costs, the politicians at least need to look at the totality. And there's not been any decent health economic studies of this. But I think it really is time someone did it. So I suggest you can introduce cannabis into the medical marketplace at zero net cost. And I'm going to keep saying that till someone disproves it. I think that's an important point to make. And of course, if you tax it, you make money. Colorado passed the $1 billion mark, just Colorado, passed the $1 billion income from tax revenue of cannabis in this last year. That's slightly out of date. So $1 billion sold, but that tax revenue was over 200 million. Market size is massive. And I think the only point for that slide is people have said, I went to the Health Select Committee in our Houses of Parliament about a month ago. People said, well, we don't know enough about its side effects yet to prescribe it safely, do we? Well, I think that's a ridiculous statement when you think about it, because it's been used for 5,000 years, and there's 164 million people use it in the world. And there's not many drugs you can introduce that's already used by 164 million people. If it had nasty side effects and turned you purple and made your limbs drop off, we would know that by now. And that we know the high THC street cannabis is an issue for some people, but we do know an awful lot about its profile and its side effects. So let's not forget, this is not a new product introduced by the pharmaceutical industry. It's an oldest medicine known to man, and we know a lot about it. And I think probably that's all I want to say, and you can have lunch. Thank you.